about initially could be summarized in the question that is implicit in these two photographs on the screen. If someone gave you the newborn infant on the left with its extraordinary potential and said you had 20 years to develop that individual into the person lying unconscious on the sidewalk, overlooked by the world, what would you have to do? Obviously, we know at some level, but we're inhibited from speaking openly about that. So in a way, that really summarizes the thematic material of the A study. How does one routinely learn what happened to each individual? And what does one do with the information once it's obtained? The answers relate directly and in unexpected ways to difficult problems in medical practice, public health, and social malfunction that we run into every day. But interestingly, this information never appears in medical histories. And the question is, would it matter if it did? Would we be smart enough to know how to use it? I'll summarize the A study findings to give you some general structure on which to hang all the data that I'll present soon afterwards. The ACE study is a retrospective and prospective analysis in 17,337 middle-class adults of the effects of 10 categories of adverse life experience during childhood. The very existence of these experiences was found to be quite unexpectedly high, overwhelmingly unrecognized, partly because they're lost in time, but further protected by shame, by secrecy, and by social taboos against routinely exploring certain realms of human experience. Their effect, a half-century later, is powerfully and proportionately related to the number of categories of adverse life experience in childhood and adolescence, and thereby is a major determinant of well-being, health risks, mental illness, job performance, social malfunction, biomedical disease, and premature death. If we're bold enough to get that information routinely, are we smart enough to know how to use it? The study began quite unexpectedly. I was not originally interested in this. In 1985, this 28-year-old woman, a nurse's aide on the night shift in a convalescent hospital, which meant something, although we didn't know that initially, showed up in a major obesity program that we're running and asked if we could help her with her problem. Our first mistake was in accepting her diagnosis of what the problem was. You look at those two photographs, before and after, and ask yourself which picture depicts the problem. Could be wrong. Using the technology of supplemented absolute fasting, We took her weight from 408 to 132 pounds in 51 weeks. And thought, my God, we must really know what we're doing. Look at the results. Our teacher here forced us to realize that we knew nothing of what we were doing, but merely were in possession of a powerful technology. And ultimately, I saw that there was a real analogy to smoke and house fires. When a house is burning down, what you see typically is the smoke billowing out of it, not the causal flames inside. We've all heard you can die of smoke inhalation, so my God, we better get that smoke treated. Bring big fans to blow it away. Except the house burns down faster. And pretty soon, homeowners flee the treatment. As is commonly done in drug programs, alcohol programs, and as we learned, obesity programs, particularly the successful ones. Here's her weight curve. Looks kind of like a ski jump. 408 to 132. Stays there several weeks. And then in one 3-week period, does what I previously had considered to be physiologically impossible. She regains 37 pounds in 3 weeks. And I remember asking her what was going on, and she said, I think I'm sleep eating. To which I remarked, I didn't understand what she meant. Well, I've been a sleep eater when I was a kid, but I hadn't. I've been a sleepwalker when I was a kid, but I haven't done that for years. But now I live alone, and when I go to bed at night, everything is clean and put away in the kitchen. Wake up in the morning, boxes and cans are open, pots and dishes are dirty. Somebody's obviously been cooking and eating there. I'm the only person. That's what it has to be, but I have no recollection of it. Okay, it's got a certain force of logic to it, even though I'd never heard of it. And why now? I mean, why not last year? Why not 2 years? Or why now? I don't know. But what do you think? I don't know. Yeah, I understand, but what do you think? I don't know. They said that. On the third pass, she stumbled and said, well, there was this man at work. He was a much older man. He was married. And he said to me, hey, Patty, you look pretty good. You lost all that weight. How about you and me making it every week? And that was the day the sleep eating began. And I remember thinking, well, it's a pretty clumsy proposition, but I mean, this is 1986. It is Southern California. It's kind of an extreme response. You know, why the extreme response? And pursuing that led to a lengthy incest history with her grandfather. I previously thought incest was pretty rare. She taught us otherwise, because her story led us to begin pursuing childhood sexual abuse histories routinely with all of our patients. And it was hard to believe initially what I was hearing. I mean, I kept thinking, this can't be. You know, people would know if this were true. Somebody would have told me. Wasn't that what medical school was for? About 18 months later, when we had detailed histories on 286 people going through the program, in the course of which we learned about other forms of child abuse that were remarkably prevalent, and then about the prevalence of growing up in massively dysfunctional households. I presented these findings in 1990 at a national meeting in Atlanta. Was pretty strongly attacked by the audience. Somebody got up and under the guise of asking a question, made the pronouncement that I really needed to know that people who were more fluent in these matters, like obviously they, recognized that these statements by patients were largely fabrications to provide a cover explanation for failed lives. It was an interesting experience, because I remember standing on the stage maybe for 20, 30 seconds wondering, do I tell this guy what I really think of him, or just let it slide and not start a riot? Well, there was a dinner meeting for speakers that night, and seated next to me was a senior scientist from CDC, David Williamson. David said to me, look, you know, if what you're saying is true, it's got enormous importance for the country as well as the practice of medicine, but nobody's going to believe your 286 cases, no matter how well you've studied them. What we need is a large epidemiologically sound study with thousands of people in it, and from a general population, not some strange subset. Yeah, okay, we could do that because we had roughly 58,000 people a year coming through the department for very comprehensive medical evaluation. How many? We settled on 26,000. Yeah, it sounds good. 26,000, okay. That was about 6 months' work for us. So here's the design of the ACE study. The dark blue box in the center represents their coming through the department for comprehensive medical evaluation. This was their own desire, you know, want to know how I'm doing, that kind of thing. It's what at the Mayo Clinic you pay a couple of $1,000s to have done. This consisted of 2 visits, very detailed medical history, very extensive laboratory studies, very detailed physical exam. The average age person was 57, almost exactly half women, half men. 80% white, including Hispanic, 10% black, 10% Asian. 74% had been to college. Basically, it was you and me. No way of dismissing this as some bizarre group that I don't see in my practice. This was basically you and me. And so we matched current health status against 10 categories of life experience in childhood, roughly a half century earlier. And then we've been following that group forward for the past 19 years, matching what happened now 50, 60, 70 years ago against current pharmacy utilization, ER visits, doctor office visits, hospitalization, and death. Here are the 10 categories that we studied. And these were selected empirically because of their high prevalence in the weight program. Major emotional abuse, basically recurrent humiliation. 11% self-acknowledged. Major physical abuse, I do not mean spanking, I'm talking serious beating. Self-acknowledged by 28%. Contact sexual abuse, not somebody flashing a kid. Self-acknowledged by 28% of the women and 16% of the men. Major emotional neglect, 15%. Physical neglect, 10%. Growing up in a home where one of the members of your household was an alcoholic or a drug user, 27%. Losing a biological parent for any reason before the age of 18, 23%. And that was interesting because we saw that the least damaging way of losing a parent was by parental death, unless that death was a suicide. Most damaging was maternal abandonment. Parental death at least offered the possibility of creating a protective mythology. If my mother would have cared for me, if my father would have protected me, if. Growing up in a home where one of the members of your household was chronically depressed, suicidal, or in the state hospital, 17%. growing up in a home where mother was treated violently, 13%. In a home where one of the members of your household was imprisoned, 5%. And I had trouble with that too. I mean, 5%, come on, that's serious. And then I remembered that I knew 2 physicians at home, one of whom was a national figure, whose sons were in the state penitentiary. They, of course, didn't speak about that very much. And of course, nice people would never ask. Actually, it was very interesting, because the IRB was a major stumbling block. Otherwise, sensible people were quite insistent that the questionnaire we were proposing to use would cause patients to decompensate. They would not agree that we could use it, feared that it would make people suicidal, if not perhaps occasionally have psychotic breaks. We battled that point 9 months before getting them to agree on the condition that one of us would carry a cell phone 24 hours a day for 3 years, to accept phone calls from people who we were going to destroy by asking them about the reality of their lives. We never got one call. Instead, I have a notebook of letters, largely from elderly women, one of which memorably summarizes the others. She wrote, "Thank you for asking. I feared I would die and no one would ever know what had happened to me." We were dealing with mountains of information, literally over 400,000 pages of data between questionnaires, physical exam forms, laboratory slips. We needed a way to simplify things, and so we created an ACE score, which summed the number of categories of adverse childhood experience. Not events or incidents, but categories. So if anything, that tends to understate the power of the relationship. And what you'll see is that only 33% of basically us had an ACE score of 0. 11%, 1 in 9 of us, had an ACE score of 5 or more categories. From a physician's standpoint, that means that every doctor in the country, no matter what he does, is going to be seeing 2, maybe 3 ACE score 5 patients every day. They'll, of course, never be recognized, but they'll be the most difficult and intractable patients of the day. We saw that if any category was present, that there was an 87% chance that at least one other category would be present, and a 50% chance that at least 3 other categories would be present. You know, not so surprising. I mean, you don't grow up in a house where mother's being beaten, but, you know, where everything else was terrific. And we saw that women were 50% more likely than men to have an ACE score of 5 or more categories. None of this, of course, will be recognized. We've all been very effectively taught as children that nice people don't talk about certain things. And my God, you certainly can't ask patients questions, or they'll be furious, and nobody will tell you the truth anyway. Here's an interview with the sister of our original patient. She too is over 400 pounds. And it would be very tempting to say, well, you know, must be genetic in this family. My God, you have 2 women over the 400 pounds in the same family. Obviously it runs in the family. But the interesting thing about that family is that everyone spoke English. That is to say, speaking English ran in the family. And we don't jump to the conclusion that therefore speaking English must be genetic. Listen to what she has to say. Because parental loss, typically through divorce, is of enormous importance to childhood onset obesity, and essentially a totally untouched subject. You know, McDonald's does it. What's the heaviest you've ever been in your life?
In excess of 400.
So the same as your sister Patty?
Yes.
Uh-huh. And
How and why did you get so fat?
Well, I was abused sexually by my uncle. And once again, I used food as a comfort. I didn't have much of a childhood because I started working when I was 13. Then I got married at 17 to get away.
How old were you when your parents got divorced?
I recall I was 9.
Did you ever see your father again?
No.
How do you think being abandoned by him affected you in the rest of your life?
It affected me a lot, especially with the growing up years, because like there was father-daughter dances and dinners, and I'd have to take an uncle, and you know, things like this. Everybody else would talk about their fathers, and mine wasn't around, and it was devastating when my mom and dad broke up. I remember it very distinctly.
Later, she begins talking about her chronic depression. Most people speak of depression as a disease. Many say it's genetic. Some say it's due to a chemical imbalance. There's something to be said for each of that. But I'd like to challenge those. What if depression were not a disease, but a normal response to abnormal life experiences? And here's the data to support that uncomfortable view. Looking at self-acknowledged chronic depression, women in red, men in yellow, you see a pattern that you're going to see repeatedly. That as the ACE score goes up, the likelihood of various outcomes goes up proportionately, so-called dose-response curve. And at ACE score 4 or higher in women, you're bumping a prevalence of 60%, and in men at 35%. Now, this is self-acknowledged chronic depression. You may understate the case a bit. On the other hand, other people, well, I mean, what do patients know about that? You can't trust that. All this data is unreliable. So we looked at self-acknowledged suicide attempts. You see two things here. One, the powerful dose-response effect. The other, that we've switched from a straight line progression to an exponential curve, indicating an internal self-worsening. ACE score 6 is not shown because its introduction massively distorts the rest of the slide. At ACE score 6, there is between a 3,000 and 5,100% increase in the likelihood of later suicide attempts compared to ACE score 0. And I remember epidemiologists at CDC told me that those were numbers, the magnitude of which they saw once in a career. Some of you may be interested in the relationship of this to institutional or military suicides. There's a great relevance because in an all-volunteer army, we put together a magnet, the army being a metaphor for supportive family that never existed. Well, I should go back a couple of slides to mention that the 10 categories that we studied, again, to our surprise, I mean, at every turn we were running into something unexpected. The 10 categories that we studied were co-equal in destructiveness. That, too, was a big surprise. We looked at prescription rates. This was easy to do in Kaiser Permanente because medication coverage is prepaid within the system. We looked at prescription rates for antidepressant medications roughly a half century after. See the same stepwise progression. So it would appear that depression has deep roots, often going back a half century into childhood. An interesting man here, very bright guy. In a way, an amateur psychopharmacologist, equally a semi-pro saloon fighter. This guy speaks of his 3 major addictions. The backstory, which ordinarily we never have, is that his parents divorced when he was 2. His mother remarried at 5. He never saw his father again. For whatever reason, his stepfather saw fit to beat him pretty much every day. He tells me that he remembers vividly one day when he's 8, he's walking to school, and the thought crosses his mind, nobody is ever going to be there for me in my life. When he's 20, he's imprisoned in Rhode Island for attempted murder of his stepfather. Gets out ultimately, becomes a good citizen, has a responsible job working on major construction projects that keeps him away from home most of the year, sends his substantial paycheck home to his third wife, a nurse who believes in him. But home still is not a place to be trusted. Listen to what he has to say.
20 to 25 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Gotten rid of the drugs, got rid of the alcohol. Next thing I got to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
And keeping the door closed to
The memories that I've blocked out with all these years with the alcohol and the drugs.
So you see what's happening to you now as related to what happened to you decades ago.
Yep. I found a way to block the emotions and the memories.
With
Drugs, alcohol, cigarettes.
So he is clearly speaking of the functional aspects of what we dismiss as dysfunctional behavior. Alcoholism, crystal meth, 3-pack-a-day smoking. Addiction, the unconscious compulsive use of psychoactive materials, is considered due to characteristics that are intrinsic in the molecular structure of certain substances. You know, you take heroin enough times and supposedly you're not going to be able to stop. I used to believe that once. Sounded pretty good. Also thought to be a characteristic of other materials like crystal meth or alcohol or nicotine. And that seems reasonable only so long as you're not so rude as to inquire into people's lives. Because what we found was that addiction highly correlates with characteristic intrinsic to that individual's childhood experiences. In other words, exactly the opposite of conventional belief. So here, I don't know about here, but it's difficult to smoke in San Diego. You cannot smoke on a public beach. You cannot smoke in a county park, etc. Even a lot of people smoke. In spite of ever ratcheting up public health maneuvers against smoking, there's really been no significant drop in the past decade or so. So here's what we thought about the relationship of being a smoker in a notably hostile environment to underlying ACE score. Pretty clear relationship. This is not consonant with conventional views that people smoke because they pass billboard ads on the way to school when they were kids, but it does fit in with knowledge about the psychoactive benefits of nicotine. The fact that it has potent anti-anxiety activity, antidepressant activity, appetite suppressant activity, and as American Indians showed in their ceremonial use of tobacco leaves of the peace pipe, I mean, they were not burning moss or oak leaves, anger suppressant activity. Not only that, but those benefits occur within 15 or 20 seconds of inhalation, whereas the risks, which are major, occur 15 or 20 years downstream. I think most of us have some experience sometimes with, well, you know, we need help now. Worry about 20 years from now, next week. But since the dramatic findings of the Surgeon General's report in the 1960s, we've forgotten all of that physiologic knowledge about nicotine, and hence have largely been playing a tough game with only half a deck of information. We looked at self-acknowledged alcoholism and the relationship of that to underlying ACE score. Wow, big surprise. Question we used was simple. Have you ever considered yourself to be an alcoholic? Since not every alcoholic wishes to so self-acknowledge, we may be understating it a little bit. We looked at the relationship of ACE score to self-acknowledged injection drug use. Again, you see strong proportionate relationship, but an exponential curve again. ACE score 6 does not fit in for the same reason, that it so massively distorts the rest of the slide when it's put in. At ACE score 6, there is a 4,600% increase in the likelihood that that individual will become an injection drug user at some point later in life, compared with an ACE score 0 individual. Let's go back to our original patient. She quickly regained all of her weight. I probably remember she regained 37 pounds in 3 weeks. In short order, she was back over 400 pounds and disappeared for 12 years. She showed up, still safely over 400 pounds, and ultimately had bariatric surgery. And at a point where she lost 94 pounds, which was not clearly visible to me, I mean, the volumetric reduction was not yet obvious, she became intractably suicidal. And she had 5 psychiatric hospitalizations within the ensuing year and 3 courses of electroshock to gain control of her suicidality. Here, about 18 months after all of that, she explains why that happened. Listen to what she has to say.
I wasn't really handling the weight loss too well. I mean, it came off too quick, and I just felt like I was losing my protective wall. It was like, you were right, there was no going back. I wasn't able to use food as my way to get fat again, to have my solution back. It's like I had lost my solution, and I was having a hard time trying to find other solutions to deal with the underlying issues of the obesity versus just using the obesity as my wall.
So that's kind of extraordinary. Because what she is saying, that what we view in public health as the problem, she's viewing as the solution. Mistaking somebody's solution to their problem is a serious error that we frequently make. It's what makes preventive medicine and public health so difficult. You'll notice that she's fairly comfortable speaking there. The reason she's comfortable is that she knows she's going to die soon, and that she will not have to serve out a full life sentence. In the antecedent 2 years, she developed primary pulmonary fibrosis. She was never a smoker, never had any air pollution exposure. This fits in, because in recent years it has become clear that some portion, the exact amount is yet undetermined, of cases of primary pulmonary fibrosis are related to the release of so-called pro-inflammatory cytokines or pro-inflammatory chemicals. We'll come back to this point. It's a subtle point of major significance, fitting all sorts of things together that I have dismissed as ridiculous 20 years ago. Here's a man's view of things This guy became obese as a child after his parents divorced, and he had to live with his violent alcoholic grandfather so that his mother could work for a living. He vividly remembers eating for solace, as in comfort food. And as he grew obese, he discovered that obesity offered advantages. So we know that at some level. You know, think of our use of the expression throwing your weight around. This guy's just lost 158 pounds. No, that's nice, but the interesting question is, why did he ever gain it originally? Listen to what he has to say.
It wasn't that I ate because I was hungry. You know, it was, when I look at it, it was just a place for me to feel safe. As a child, I remember there was a point, I would probably say, all the way from kindergarten to, God, I don't know what grade, but I used to get beat up all the time. All the time. And when I got the weight on, didn't happen. Didn't happen.
See, ultimately what we learned from these patients was that teaching people how to eat right, you know, referring them to a dietitian, is what you do when you don't know what to do. Nutrition is an important subject, even interesting. It has no more to do with obesity than it has to do with anorexia. We looked at a wide range of outcomes, including promiscuity, which we defined as 50 or more lifetime sexual partners. Again, you see the same stepwise proportionate relationship. And ultimately, we came to see that what we're really looking at here is looking for love. That sex is a metaphor for intimacy, intimacy being the metaphor for love, which is absent. So surely the next one is the one who's going to care for me. And if not that, well, surely the one after that. And similarly, the role of pornography becomes obvious as simply the graphical depiction of searching for that metaphor for love. We looked at teen sexual behaviors. Left-hand column, the relationship of underlying A-score to early onset intercourse before the age of 15. Center cluster, relationship of teen pregnancy to underlying A-score. Right-hand side, relationship of teen paternity to underlying A-score. We looked at the relationship to rape, which I one time naively thought was fairly uncommon. You see a very powerful relationship to rape. At A-score 4 or higher, the probability of later being raped is 33%. The real question here is, what are the intermediating links that make that happen? We looked at the relationship of underlying A-score to the likelihood of becoming a perpetrator of domestic violence. We're used to thinking of women as the victims of domestic violence, but that's merely our naive view, because their victims are their children, who are typically not in much of a position to make that known. And what you see is the impact is essentially the same for women and men, but the full story is largely untold. We looked at how this plays out in the workplace. Toxic environments are real enough at some work sites, but not nearly as prevalent as toxic childhoods at those work sites. Left-hand set shows the relationship of absenteeism to underlying A-score. Central cluster shows the relationship of self-acknowledged having serious financial problems to underlying A-score. Wow, that's a switch. The implications of that are that poverty is an outcome, not a primary cause, at least in first world countries. That's a big idea. And maybe that has something to do with why Lyndon Johnson's well-intentioned war against poverty never really played out. In the right-hand set, serious problems performing my job adequately. Again, a clear relationship to underlying ACE score. In terms of medical outcomes, we looked at a lot of those. Relationship of ACE score to later liver disease. Well, you know, it's obvious. I mean, my God, you shoot up on the street, you're going to get chronic hepatitis, of course. You know, drink enough, you're going to get liver damage. Well, that turns out to be a beginning. But nevertheless, I was reminded of T.S. Eliot's famous quote, "In my beginning lies my end." We looked at COPD, relationship of COPD to underlying ACE. Well, again, you know, if you smoke, of course, you're going to get emphysema. But when we looked at that carefully, what we saw was that indeed there's a clear relationship of COPD to emphysema, to underlying ACE score because of smoking. But when we looked at constant levels of smoking, you know, pack a day, 2 packs a day, 3 packs a day, obviously not everybody at any of those levels gets COPD. The determining characteristic at any given level of smoking turns out to be underlying ACE score. That was kind of an interesting and disturbing idea. I mean, how does that work? How does life experience translate into structural disease other than by various coping mechanisms like smoking? Because at any constant level of smoking, not everybody gets COPD. Who does is related to underlying ACE. We looked at coronary artery disease, heart attack, angina, etc. Pretty much everybody knows now that since the Framingham study, there are certain risk factors for coronary. So you get coronary disease because you smoke, your cholesterol is high, you have high blood pressure, you're diabetic, etc. And all that's true. And most people don't know that about 10% of patients with coronary disease don't have any of the Framingham risk factors. Well, how do they get it then? When we looked at them, people with coronary disease but with none of the conventional risk factors, we saw that in that group there's a distinct relationship to underlying ACE score. After you've taken out the possibility of various coping mechanisms, like smoking, etc. Well, it turns out, and this is relatively recent information, it turns out that under conditions of chronic major unrelieved stress, where there is continual hyperstimulation, first of the hypothalamus, then of the pituitary, then of one's adrenal glands, the whole immune system comes into dysregulation. And oftentimes, part of that dysregulation, is the release of pro-inflammatory chemicals, pro-inflammatory cytokines, that cause inflammatory changes in the linings of the smallest blood vessels, arterioles, etc. Sometimes causing them to attract cholesterol, precipitate out, sometimes causing that tiny blood vessel to shut down completely, turning to scar tissue, whatever piece of organ they were supplying. So in recent years, it has become evident that some portion of cases of primary pulmonary fibrosis are due to this situation of the release of pro-inflammatory cytokines, as presumably was the case with our first patient. This is a pretty big idea, because in essence it says you have two ways of getting from life experience to structural disease downstream. One, through various coping mechanisms. Heavy smoking, heavy overeating, heavy drinking, buying antidepressants on the street called crystal meth, things like that, promiscuity, hazards. The other category, through the more complex issue of chronic major unrelieved stress and its effects, first on the brain central nervous system, secondarily on one's immune system, and the complexities there. There's a third category too, epigenetics. At the time we put the ACE study together, that word was barely heard of. The field has advanced enormously. We did not study anything about that in the ACE study, but clearly would be the third path. So ultimately, you're stuck with the question is, you know, why are these things so difficult to deal with? What is, you know, I mean, aren't kids resilient? You know, doesn't time heal? It really doesn't. Time conceals. Aided by shame, secrecy, social taboos against exploring certain realms of human experience. That issue is often concealed by intellectual success, or social success, etc. Give a moment's thought to the number of suicides that you've known, where some trivial, oh, something must have snapped. Yeah, right. I mean, what we've seen is that the roots of that go back decades. These are two PET scans. PET scan being this very sophisticated kind of X-ray depicting biochemical activity in color superimposed on anatomic structure. These are PET scans of 2, 3-year-old little boys. PET scan on the left is an ordinary American kid. PET scan on the right is a little boy taken from a Romanian orphanage, institutions that were noted for the extraordinary levels of neglect imposed on the inmates. And what you see on the right is large areas of brain where there's no color, where there is no biochemical activity going on. And I don't think at age 3 it's going to tax anyone's imagination too much to think, well, maybe that lack of biochemical activity might affect the kind of brain that's being formed. In other words, what we're looking at here is the conversion of life experience into neuroanatomy. And maybe that has something to do with why these things are so difficult to deal with after the fact. You could summarize what we've said thus far in this way. You have this very large base of individuals with adverse childhood experiences, overwhelmingly unrecognized because you have to inquire routinely. Obviously, I mean, my God, you can't ask patients questions like that. Why, they'll be furious and nobody will tell you the truth anyway, etc. Producing, we now realize in recent years, disruptions in neurodevelopment. Producing, obviously, all sorts of impairments. Maybe this is the socially isolated kid, the weepy kid, the one who has trouble learning in school. By the time they become teenagers, they have enough freedom to try to do something that helps. Nicotine helps. Sex helps. Alcohol helps. Crystal meth helps. given time, those things that help initially produce their own set of problems. So in middle age, you see disease, disability, social malfunction. A number of people die early. We recently have a paper out showing that at ACE score 6 and higher, there's almost a 20-year shortening of life expectancy. So in summary, what we found was that adverse childhood experiences are the most basic and long-lasting cause of health and risk behaviors, of mental illness, of social malfunction, of structural disease, of disability, premature death, and obviously healthcare costs. And that there's a public health paradox, that what are conventionally viewed in public health as problems are often, from the individual standpoint, unconsciously attempted solutions to long-concealed adverse childhood experiences. I mean, this is a big idea, and it underlies the failure of many of our public health approaches that mistake somebody's attempted solution as the crux problem. It helps to remember that the demonized crystal meth is the very same chemical that in 1940 was introduced in the United States as the first successful prescription antidepressant. Does it matter that this most commonly sold street drug has potent antidepressant activity? Does it matter that nicotine has potent anti-anxiety activity? And that occurs within 20 seconds of inhalation? Its risks are years away. Well, yeah, I mean, one way it matters. It's a lot easier to save my kids on that damn crystal meth because there's a dealer on the next block than it is to save my kids buying antidepressants on the street. To fix this idea in your mind, here's a full page ad from an issue of the Journal of the American Medical Association in the early 1940s for the successful new antidepressant, methamphetamine. Had a couple of different brand names, depending on who the manufacturer was. Let me reinforce this idea. The old lady here has something important to say. You supplied me recently a lengthy autobiography, a number of dozens of pages altogether. And on the very next to the last line, you said something that I thought was extraordinary. Let me read it to you because I think it's remarkable. I believe smoking 3 packs a day and weighing 300 pounds are not the problem. They're the symptom. It took us a long time to figure that out here, and you just actually dropped that as though of course everyone knows that. So you are in respiratory failure on 24-hour-a-day oxygen.
Yes.
Major amounts of weight, overweight.
Yes.
And you demonstrated, or we demonstrated together a couple of years ago, that when you had a major weight loss in the OptiFast program here, that your need for oxygen disappeared.
That's correct.
So if you lost 150 pounds approximately, the need for oxygen would no longer be there. The weight came back. Most people have very little understanding of why people get fat or regain. I mean, they're stuck with this simple belief, don't you know it's bad for you, etc. And people tend to know even less about smoking.
Yes.
It's labeled an addiction and it's though that somehow explains it all.
Right.
Etc. And you make this extraordinary statement about what we perceive as the problem really being the solution. Can you explain more about that?
Yes. I think I've come to that conclusion. It hasn't been quite immediate. It's come to me over the last few years of analyzing just exactly where I've been and what I've done. Obviously, I was a 3-pack-a-day smoker when I was thin. I didn't have a weight problem until after I was 35. But I've done several Optifast type things, and I finally came to the realization on my own that the reason I put the weight back on was to protect myself.
Here's where all this work was carried out. Interesting place. Ultimately, it was clear that what we were learning needed to be integrated into everyday medical practice. And while most of my colleagues were very interested in hearing about this intellectually, everybody had good explanations for why they themselves could not touch this with a pole. So, with the huge throughput through the department, we decided to integrate so-called trauma-oriented questions into our general medical questionnaire, 10 to 12 pages long. It was filled out at home before coming in, not on a clipboard in the doctor's waiting room. I can't tell you what a poisonous approach that is. How many patients have said to me, if I wanted the damn clerk to know about my life, I wouldn't be paying the doctor. Questions like, have you ever lived in a war zone? Have you ever been a combat soldier? Who in your family has committed suicide? Who in your family has been murdered? Very practical question with ignorant populations. Who in your family has had a nervous breakdown? Were you ever molested as a child? Ever held prisoner? Ever tortured? Ever raped? And the use routinely of these and related questions transformed our ability to understand and treat many problems that previously seemed intractable or were misunderstood. Looking at our prior way of operating, which was a very high-end biomedical evaluation, that was associated with an 11% reduction in doctor office visits in the year subsequent to going through. So, my impression, I was very pleased. This is due to more fulsome diagnosis, more skillful entry of people into a complex medical care system, etc. So, probably that was mostly true. When we switched to what George Engel would have called a biopsychosocial evaluation with the integration of trauma-oriented questions routinely, in a 125,000 patient sample, 2.5 years throughput for the department, an outside group in the data mining business demonstrated that there was associated a 35% reduction in doctor office visits in the subsequent year and an 11% reduction in ER visits in the subsequent year. Now, for anyone who's interested in the dynamics of medical care or the economics of medical care, that might be of some interest. Now, in Kaiser Permanente, our outpatient budget in Southern California is $6.5 billion a year. So if this is replicable, and that huge sample suggests it might be, and 35% of $6.5 billion, that was serious money, even by federal standards. This has gone nowhere. And that's a very important thing to realize. That whereas this material has attracted intense intellectual interest, the resistance to using it is even greater. If you ask me what can we do today, I would say routinely seek a history of adverse childhood experiences from all patients, or if you're a pediatrician, from their parents, if you're running a prison, from the inmates. Well, what do you do with the information? I mean, what would I do if I asked and somebody said yes? Remember this sentence. I see on the questionnaire math. Can you tell me how that's affected you later in your life? Because that's what we did in the exam room. I see on the questionnaire that. Can you tell me how that's affected you later in your life? And we listened for a minute and a half, 2 minutes. Patient responses were amazingly concise. And we listened, period. People ask, you sent everyone to therapy, right? Absolutely not. Essentially no. We listened. And implicitly we're accepting people, which is a big deal because this was the first time, overwhelmingly, that they have ever told anyone. We have existing systems to deal with currently recognized problems. They're imperfect and they're inadequate in volume. What we really need is to develop systems for primary prevention. No one knows how to do that, but it's the right question to focus on. You're really in the ideal position to work out that solution. So I'll close this way. What we saw was that adverse childhood experiences are very common but typically unrecognized. That they're linked to major problems later in life is strong, makes sense, and proportionate, the dose-response curve. That they're the nation's most basic public health problem. That it's comforting to mistake intermediary mechanisms for basic cause. No, I'm not taking this Prozac because I'm depressed. My doc says I have a chemical imbalance. That what presents as the problem may be somebody's attempted solution. Treating the solution may threaten people and cause life from treatment. And the change will be resisted by us, in spite of huge personal and economic benefits. If we can figure out how to circumvent that resistance, that might be the major advance in public health for the next several decades. So what you do matters now, today, matters decades from now, and it matters in the next generation. If you're interested in more information, here are some sources